of labor. This is called premature rupture of membranes, or PROM or PROM. Don't get this confused with PPROM or PPROM. This is actually preterm premature rupture of membrane. So you'll be tempted to think when you hear premature on just PROM that this is a preterm situation, but it's not. You have to be PPROM in order for it to be a preterm, meaning that the baby is less than 37 weeks gestation and there's a rupture of membranes. Next. So you think this would be an easy thing to figure out. A giant gush of water coming out of the vagina would be a hard thing to miss. But it's not always a gush. You know, sometimes you get a tiny trickle. Sometimes if they've been losing amniotic fluid for a long period of time, they just don't have much amniotic fluid left, so you're not going to see a lot going on. So you have a pregnant woman, often will come in swearing that they've had a rupture of their membranes. That I've broken my water, I'm sure I'm going into labor, you know, help me, help me, help me. But oftentimes you'll find out in labor and delivery, especially in the triage after you do all your tests, that it ended up just being that the baby source shifted, mashed on the patient's bladder, and the liquid was actually just urine. So how do we figure this out? Well, commonly used tests for this are pooling, the Fern test, and nitrazine test. So first, by using a sterile speculum, you try to visualize a pool of liquid in the vagina. So if you can have the patient bear down, if you can actually look at the cervix, and if you see fluid coming out, then that's a pretty good sign. So if you see pooling, that's a very good indication that you have a rupture of membranes. Next, you can collect some of that pooling liquid, or if you can find some other liquid in the vaginal wall, you can put it on a microscope slide and let it dry. The estrogens in the amniotic fluid will cause crystallization of the salts in the fluid, and this resembles the blades of a fern under low microscopic power. So if you get a little bit of that goo, put it on the slide, let it dry. If you see fern, another good indication this is a rupture of membrane. The last one is the nitrazine test. Now, when you take another sample of the pooled liquid, then you can place it on nitrazine paper. If it's amniotic fluid, which is alkaline, the paper should turn immediately blue. But don't take a Q-tip and stick it into the cervix for this, because that can give you an abnormal test there. Make sure you're actually getting fluid from the vaginal vault. An ultrasound can also be very helpful. Again, sometimes if someone's had a long-term leak and they just don't have any amniotic fluid left, then that might really mess up your test, because you're really not getting those good positive tests. You're not going to see a lot of pooling. So if you do your ultrasound and you see no amniotic fluid around the baby, that could certainly increase your likelihood of having some sort of rupture. There is a newer test called Amnisure, and this tests for alpha microglobulin 1. And this is an immunoassay which appears to have a little bit higher sensitivity and specificity than our previous test that we just talked about, but it's more expensive, so I haven't seen it used, but it might be something that's used more and more in the future. Okay, so we've determined if the membranes are intact or ruptured, and the next step is the cervical exam. So this is the tricky exam that will take a little bit of practice over time, but you'll get through it, I promise. Many clinicians will use 5 components of the digital cervical exam to monitor the progression of labor. They include dilation, effacement, fetal station, cervical position, and consistency of the cervix. Now these are referred to as the Bishop score. So you'll hear this several times throughout the lectures in obstetrics, the Bishop score. And this score will indicate whether or not it's favorable for a spontaneous labor. So anything usually above 8 is considered favorable for a spontaneous labor, and it's composed of those 5 things. So first, dilation. That one is probably, I wouldn't say the most important, but maybe the most important out of all these in the Bishop score. In general, the measurements range from 0 to 10 centimeters, and 10 centimeters is considered fully dilated. On average, the baby's head needs 10 centimeters in order to get through, so that's why we call it full. Once you get to 10, that's sort of the end of the story. So you're going to use 2 fingers to measure the cervical opening. I recommend you practice this. You know, they do have, I remember in training we had this plastic tray that had sort of different sizes of circles, and you can kind of put your fingers in them and figure out which one it is. Because everyone's fingers are a little bit different. You know, I've got relatively big hands, so it's going to be a little bit different. You know, I found out with my 2 fingers together, that's more like 3 centimeters or a little less than 3 centimeters. If I'm not going to stretch very far, that's kind of 5-ish, and if I'm really pushing hard and I'm stretching, then that's 10. But everyone's going to have their different feel on all these things, so do practice it. It is hard when you're in there in an exam going, well, gosh, is that 3 or is that 4? And it is a bit subjective sometimes. Next is effacement, or thinning of the cervix. You know, the typical cervix is somewhere between 3 and 5 centimeters, but we don't measure this in centimeters like we did with our dilation. Instead, we measure what percentage of the cervix has thinned. So again, this is even a little bit more subjective depending on who's doing the examinations. So if we started with, say, a 4 centimeter cervix and now we're down to 2 centimeters, then we say that the cervix is 50% effaced. At 100% effacement, the cervix is as thin as the adjoining lower uterine segment, so it just sort of feels like an opening hole at that point, and there's no ridge or lining to it. Our next thing is station. This is the relation of the fetal head to the ischial spines of the mother. So when the lowest presenting part is at the level of the ischial spines, we refer to this as zero station. When the head is above, then we use negative numbers, and when the head descends below the ischial spines, then we use positive numbers. Now there's a couple of different point scales. We have a 3-point scale and a 5-point scale. So you'll start off on the 3-point scale at -3, then -2, then -1, then 0 station, then 1, 2, 3, and the same thing with just 5 on the other one. Now this will take some experience to sort of get the feeling of where the station is. But know that at the level of the introitus, which I just said, that's either going to be +5 or 5 station or +3 or 3 station. ACOG tends to like the 5-point scale, but some hospitals and some residency programs are going to use 3-point scale. So just figure out which one is being used, try to get used to it, or maybe try to get used to both. Cervical consistency is our next one, and it's just how firm or how soft the cervix is. It's hard to describe that. Usually a cervix that is not dilated at all is going to feel pretty firm. You may not be able to really wiggle your finger into it. And then obviously a soft cervix is going to feel soft. And obviously a soft cervix is more favorable for labor. Cervical position can range from anterior to mid to posterior. Especially when you're inexperienced, a posterior cervix will drive you crazy because you'll be examining the patient and you'll think to yourself, I found the first pregnant woman without a cervix. Because you're just not going far enough down and around. It can very easily kind of get low on you and back behind the baby's head, so you'll be going in for an exam and be like, oh, I can't feel anything, but you have to really, sometimes you have to kind of torque your arm around depending on how things are going. It's not much fun for the mother either if they've got a real deep posterior cervix. Putting more pressure and more of your hand into a vagina is not very comfortable, so be aware of that and try to be as gentle as you can. All right, next I want to talk briefly about fetal presentation. In the early stages of labor and with little cervical dilation, it may be difficult to determine the fetal presentation. You know how we talked about this before. If you have any questions, use an ultrasound. But when you're doing your cervical exam, you can probably get an idea if you're feeling a scalp or not. So you ought to be able to figure out the presenting part most of the time, but now we need to figure out which direction this head is pointing. The fetal position in the vertex position is usually based on the relationship of the fetal occiput to the maternal pelvis. So you'll get names like occiput posterior or OP. So this is if the mother is lying on her back, the baby's head is facing up. So if you imagine if you're looking at a woman, you notice that baby's face will be going up this way and the back of the head will be back down here. So that's OP. Why is this important? Well, certain positions can lead to prolonged labor and have a higher rate of C-section, like occiput transverse or occiput posterior. So OT, OP, you're going to have harder times getting those babies out. So how can you tell the position of the baby? Well, it helps to have a dilated cervix, so you'll be able to feel a lot of the baby's head, but you may not have that early on in labor. The position is determined by palpation of the sutures and the fontanelles on the baby's head. So the fetal skull is composed of 5 bones. You have 2 frontal bones, you have kind of 2 side bones or parietal bones, and then you have the 1 occipital bone. So the anterior fontanelle is the junction between the 2 frontal bones and the 2 parietal bones. And this fontanelle is the bigger one. It's shaped kind of like a big diamond, and it feels bigger. Now sometimes that's hard to tell if that's all you can feel. Like, well, is this one bigger than the other one because I can't feel the other one. The posterior fontanelle is smaller, shaped more like a triangle. So when you're describing the position, we find the occiput. Hopefully you can kind of tell the difference between the anterior and posterior fontanelle, then that'll kind of point you in the right direction of where it's going. And then in relation to the mother's pelvis, that's how you figure all that out. All right, so let's recap what we've done so far. We've checked the patient's records, we've looked at the dates and the ultrasounds, we've looked at all the screening labs.